All right, hello everybody. I would love to kind of flip-flop our topics around. After exam 3, I guess the syllabus said that we would start out with cardiovascular and systemic infections, but I thought it might be a good idea to kind of flip-flop those with the respiratory system, since we did go ahead and right before spring break we started the respiratory system. And we covered sort of viruses of the upper and lower respiratory system. Remember, we talked about like common colds, and then we talked about influenza, and then we talked about the COVID-19, and then we did the COVID-19 activity. So I'm not going to, excuse me, cover with you all of the components, because remember, we did talk about the upper and lower respiratory system before. We talked about it when we covered that. These are the components of the upper respiratory system, just to remind you. These are the components of the lower respiratory system. And then here's sort of what it looks like put together. I remember talking to you all about the little flap, sort of that when you swallow kind of closes off the airway from your esophagus, which goes down into the digestive system. So at that point, this is where sort of right at this epiglottis is where you start entering into the lower respiratory system. And this is where sort of the digestive system and the respiratory system separate from each other, because in the upper respiratory system, they're really connected. The mouth and throat is part of the digestive system, but it's also part of the upper respiratory system. So up at the upper respiratory system, this series of mucous membranes is really connected at that point with the digestive system. But at the lower respiratory system, they're not. It's the epiglottis. So when you swallow food, this epiglottis flap covers the opening of the trachea there. And it forces the food then down into the esophagus. So at this epiglottis, right below it is the larynx, that's your voice box, the trachea, which is the large tube leading down into the lungs. It divides then in two, and you end up with the bronchus, bronchi if plural. Those further branch out into bronchioles. And then at the end of the bronchiole, here it is blown up, you see the little alveolar sacs. This is where gas exchange occurs. You see that there's lots of blood vessels and veins. Well, excuse me, these are capillaries. They're really, really small. So they're going to be tightly and intimately woven around and connected to these sacs. And so when you inhale in the oxygen can then diffuse into the capillaries, and then it gets delivered. That oxygen gets delivered to all your cells that need that oxygen. And then the blood vessels or the capillaries that are full of CO2, that CO2 then diffuses out of the blood vessel into the alveolar sac where you can exhale it out. All right, remember we did talk about the fact that the lower respiratory system is typically sterile. They say it's axenic, A-X-E-N-I-C. This is just because typically organisms aren't present. The upper respiratory system does a really good job of filtering those out. However, the upper respiratory system is colonized by a number of organisms. And so I'm going to talk to you now about bacterial diseases of the upper and lower respiratory system. There are many normal microbes that are present there in the upper respiratory system, and in general, I could say, and in normal sort of conditions where the person's in a healthy status and their immune system is healthy and strong as it should be, the normal microbes there they actually prevent growth of infectious pathogens that cause disease. However, these normal microbes are not all good microbes. Some of the normal microbes are staph and strep bacteria, which definitely have the capacity to cause disease. And so in some cases, and for some instances where we don't really understand exactly what's happened, these normal microbes can become opportunistic pathogens and cause disease. All right, so a good example of normal microbes that could possibly cause disease those are going to be streptococcal respiratory diseases. You've probably heard of those. There's actually a variety of diseases of the respiratory system caused by streptococcus, and we kind of characterize it and classify it depending on the site of infection, the species and strain of bacteria specifically, and the immune response or status of the pathogen. So streptococcal pharyngitis. This is a really fancy way of saying strep throat. Signs and symptoms of this. I mean, streptococcal pharyngitis is an inflammation of the pharynx or throat region caused by streptococci. The back of the throat is going to appear red, swollen lymph nodes. You're going to have purulent or pus-containing abscesses covering the tonsils. Usually there will be fever, malaise where you just don't feel good, and muscle aches, and then headache can accompany the pharyngitis. If bacteria spread down further into the lower respiratory tract, they can cause inflammation of the larynx, and you could get laryngitis. So it could be streptococcal laryngitis if it's in the larynx region. You could also get bronchitis if the inflammation and infection is in the bronchi. Laryngitis is, of course, going to manifest itself as hoarseness and sore throat. You've probably had that. Bronchitis, on the other hand, is going to manifest itself as sort of an itchy cough. You're going to have reduced airflow, you're going to have mucus production and accumulation, and you're going to have massive coughing. You can also get scarlet or rheumatic fever. This really depends on the strain of the strep. In order for you to get scarlet or rheumatic fever, this would have to be a strain of the strep that has a specific, it has a gene for a specific toxin. The toxin is called a pyrogenic toxin. This is an exotoxin that is known to damage the plasma membrane of blood capillaries under the skin. So this pyrogenic toxin, it does cause a fever as well. So it triggers a fever. That's why we call it scarlet fever. But in addition to that, it's damaging the blood capillaries below the skin, and it produces a red rash. So when these capillaries become damaged, they burst, and it releases blood close underneath the skin, and they become inflamed and ruptured, and you're going to have this rash that forms. Right. This is generally going to happen if you've got strep throat caused by a type of strep that has the pyrogenic toxin. Then you could see scarlet fever occurring in 1 to 2 days into the pharyngitis. That's when the bacteria typically begin to release their toxins if they have that gene. And that's when you start seeing the fever and rash begin on the chest, and it should spread across the body. Untreated strep could lead to rheumatic fever. This is different than scarlet fever. Scarlet fever is due to untreated strep that has the pyrogenic toxin. Rheumatic fever is slightly different. Rheumatic fever is when strep actually progresses past the site of the throat, and you end up with a disease of the heart and of the kidneys. So what happens is you get scarlet fever, rheumatic fever. The strep throat leaves the side of the throat. The strep throat bacteria leave the side of the throat, and they can travel to and infect the valves of the heart and or the kidneys. The kidneys aren't muscles. The exact mechanism isn't really known. But what happens is this can really cause damage. We think that the immune system then attacks the area where those strep bacteria are now, on the heart valves or in the kidneys. And so it attacks the heart valves, and then it attacks the kidneys. And so you get damage to the heart valves and damage to the kidneys, scarring of the kidneys. In some cases, it can be bad enough that surgeons must replace the heart valves when they reach middle age if they've had rheumatic fever as a child. Other virulence factors. They can have a hyaluronic acid capsule. This means the strep throat bacteria have a capsule full of hyaluronic acid. And if you remember, hyaluronic acid was a molecule commonly found in tissues, skin, and other connective tissues of humans. And so if the strep bacteria is hiding in a capsule made of this molecule, it's hard for the immune system to determine that this is, in fact, a foreign cell. It will mask the cell and make it look like it's a human cell. There's also enzymes called streptokinases. Remember, we talked about kinases? Kinases are able to break down blood clots. And so kinase is going to presumably allow the strep bacteria to spread easily through damaged tissues. Streptolysins, these are other exotoxins, extracellular enzymes that will actually lyse red blood cells, leukocytes, which are white blood cells, and platelets. All right, so how do you know if you've got strep throat? This is a really lovely image. So you can get viral infections of the throat, pharynx region, larynx region, bronchus region. All of these regions can be virally infected. Typically, if you have a viral infection of the upper respiratory system, you can have similar symptoms to what you might see with bacterial infections. You might see red swollen tonsils. You might see throat redness. You might have pain, fever, malaise, soreness when swallowing. However, what you typically don't see, is the purulent, pus-containing spots. You don't see pus and white patches or yellow patches growing on the back of the throat here. In bacterial infections like strep throat, you will. You will see whitish spots. These are the purulent, pus-containing spots where the bacteria is growing, where the immune system cells are rushing in and trying to fight the infection, and they're dying. Bacteria are dying, and you end up with these purulent, pus-containing spots that can typically, they can start out smaller. They could be more like this, what you see down here, covering these tonsils and back of throat. It could be more spotty, like what you see here. It could be yellowish, like what you see here. You also notice a gray, furry tongue, whitish, yellowish, grayish, whatever you want to call it. There's going to be bacteria coating the surface of the tongue. If you have those symptoms, like what you see here, or here, you need to go to the doctor because you will need antibiotic treatment if, in fact, you do have bacterial pharyngitis. Scarlet fever, like I said, if you end up with a strep infection and this particular species of strep has the pyrogenic toxin gene, not many of them do, and actually we're seeing this decrease, and there's not many cases of this currently. However, it could still happen if you get infected with, like I said, the strain of strep that has the pyrogenic toxin gene. If you do, what will typically happen 1 to 2 days into the strep throat, you will start to see a strawberry-looking tongue. The tongue takes on this strawberry appearance where some of the taste buds are rather swollen, and so they kind of look like seeds on the strawberry. You will see the results of the pyrogenic toxin. Like I said, this pyrogenic toxin, once it's produced, it's an enzyme it's an exotoxin. So it's an extracellular enzyme that's secreted out of the strep bacterial, the bacterial cells, and it goes out and it binds to the capillaries underneath the skin, and so it's causing damage to these capillaries, and you see they rupture and it results in this reddened rash that starts on the trunk of the body and can spread along the limbs. All right, so when do you get strep throat, right? Because I mentioned that you have lots of bacteria in the upper respiratory system, and these bacteria typically do protect you. And it turns out that we actually do have more strep infections than we think, okay? Strep bacteria are part of these normal microbes that are present in the upper respiratory system, and they can, when conditions are right, they can cause infections. And then apparently they commonly infect the pharynx, but infections are usually limited and cleared within a week or so in healthy people. And our adaptive immunity will kick in and direct itself against the pathogen and the toxins, and the strep throat never actually manifests itself, and we don't actually ever get sick. Actual strep throat usually only occurs when the normal competing microbes are absent, or if the person is exposed to an overwhelming number of new strep microbes all at once. If that happens, like if you were around somebody that had strep throat and they were really sick and microbes were coming out, maybe they're coughing and microbes are coming out, and you inhale a lot of strep bacteria at once. If that happens, that high number of bacteria could usually overcome and outcompete the normal microbes present, and they can gain a very swift foothold before your immune system can kick in. Or it could happen when, adaptive immunity is impaired. Maybe your immune system is lowered. Maybe you're stressed. You've got some other illness, something like that's going on. And these normal microbes now cause strep throat. Strep throat is spread by respiratory droplets, and it is seasonal. So it's most often in winter and spring, although you can definitely have strep in other seasons as well. As far as treatment goes, before antibiotics, streptococcal diseases actually claim the lives of millions. But luckily it is sensitive to antibiotics, and so we can treat, thousands of Americans are sickened each year with strep, and we're treating them obviously with antibiotics, and they're generally cured. Incidence of rheumatic fever is down. We have had no cases after 1994. Scientists don't fully understand why the rheumatic fever incidences are down. They think maybe it's antimicrobial drugs, and possibly a natural decrease in the number of species and strains capable of producing rheumatic fever has also occurred for some unknown reason. All right, let's see. Other infections, bacterial infections of the upper respiratory system include diphtheria. Signs and symptoms of diphtheria. This is very different from strep throat, and diphtheria is not part of our normal flora, not part of the normal microbiota like the staph or strep bacteria were. Diphtheria is caused by Corynebacterium. Actually, I might have lied to you on this. No, it's true. Diphtheria is not. Yes, it is. So, diphtheria is a gram-positive bacteria which is ubiquitous in mammals and humans, and it colonizes the skin, respiratory, gastrointestinal, urinary, and genital tracts. So, it is ubiquitous in humans. However, there is a vaccine. So, routine vaccination has brought the deadly childhood disease diphtheria under control, at least in developed countries, not developing, but developed countries. The disease still is a major threat to those in developing countries or less developed regions of the world because they don't have access to the vaccine. All right, so it's Corynebacterium diphtheriae that causes diphtheria. Signs and symptoms, diphtheria is generally going to manifest as a sore throat. There's going to be localized pain, fever, and oozing of a fluid composed. There's a fluid that oozes into the throat. And this fluid is composed of cellular fluid, blood clotting factors, white blood cells, bacteria, and the remains of dead throat and larynx cells, voice box cells. The fluid will then thicken into what's called a pseudomembrane. All right, this pseudomembrane is what gives the disease its name. Diphtheria in Greek means leather, and this pseudomembrane takes on a very tough, leathery consistency, and it adheres so tightly to the tonsils and the uvula and the roof of the mouth and the pharynx and the larynx. It adheres all over the back of the throat region. It's terrible, and it cannot be dislodged. It is so thick and adheres so tightly that it can obstruct airways and cause suffocation. You can't dislodge this thing without ripping a layer off of the throat. All right, so it rips the underlying tissue that it is attached to, and it causes bleeding. In severe cases, like I said, it can obstruct the airway and cause suffocation and death. All right. The damage to the back of the throat, causing death of the white blood cells and death of the larynx and pharynx cells, it is all due to this diphtheria toxin. This diphtheria toxin is what's called a cytotoxin. All right, remember we talked about exotoxins, we talked about neurotoxins, we talked about enterotoxins, which cause like diarrhea. We'll talk about those more soon. But we also mentioned cytotoxins, C-Y-T-O, cytotoxins. These things will actually cause damage to cells in the host, and they can cause cell death. And that's what's happening here. This diphtheria toxin prevents protein synthesis in the white blood cells, in the throat cells, in the voice box cells, and it causes them to die. And then they build up and they leak out their fluid, and the dead cells build up, and it's what causes this membrane. All right, let's look at the membrane. Here it is. What you see, this is the pseudomembrane starting. You see all this fluid exudate that is leaking out of the dead and dying cells. Over here, here's the pseudomembrane. This is the membrane that attaches so tightly to cells in the back of the throat, and it goes deep down to the voice box area. You can't pull it out without damaging the tissue. All right. Person-to-person spread. So this is a contact spread transmission. It is spread by respiratory droplets, so indirect contact. Respiratory droplets or fomites. You inhale the droplets, or you contact a fomite that has had a droplet land on it, or direct skin contact with someone and the bacteria are on them. Diphtheria is endemic, like I said, in developing or underdeveloped parts of the world where immunization and vaccines are not readily available. And before immunization and before vaccines were available, hundreds of thousands of cases of diphtheria occurred in the U.S. each year. However, now cases are very, very limited, almost absent. Diagnosis is done based on that pseudomembrane because this is very unique to diphtheria. What they're going to do is treat you with an antitoxin. So these are antibodies created to that diphtheria toxin. These antibodies will neutralize the toxin. And then they're going to treat you with antibiotics to kill or inhibit the Corynebacteria bacterium. All right. Sinusitis and otitis media. These are really fancy ways to talk about. If you say sinusitis, this is a sinus infection. If you say otitis media, this is an ear infection. And so these are just infections of the sinuses or the ear canals. And so we're naming them on the location. Again, this can be caused by various respiratory microbes, including Streptococcus bacteria. Sinusitis, of course, is going to cause pain and pressure in the region affected. You're going to have inflammation in the sinuses. Otitis media is going to have pain or pressure in the ear canal. You probably have malaise or headache with both of these. Interestingly, otitis media is much more common in children, and it is basically going to be due to the fact that children have eardrums and ear canals that haven't fully formed yet, and they're more horizontal than they are in adults. They're more horizontal, and so fluid and bacteria can easily accumulate. And in adults, they're going to be more vertical. They're going to have more of an angle to them, and so they can easily drain, or more easily drain, and so you see these infections less often in adults. As far as how they're spread, like I said, it's caused by various respiratory microbes that may already be present. So it could be opportunistic, or it could be due to exposure to a large number of organisms, like we said for strep throat. So Streptococcus, Staphylococcus, and many others can cause sinusitis and otitis media. There is some evidence, though, that if you've had damage to the mucous membranes of the upper respiratory system or auditory tubes, so like your ear canals, from past viral infections, it could make you more likely to get sinusitis or otitis media. Also, if you're exposed to cigarette smoke or other irritants, that can cause inflammation or irritation of those mucous membranes, that can also allow normal microbes to become opportunistic pathogens. In the case of ear infections, physicians might take drastic, if they are recurring, because they can be really common in children, and some children have them, it just seems like repeatedly, one after the other, especially these ear infections. They can sometimes take drastic measures to try to treat and limit earaches. So they might lance the eardrum to relieve pressure. They might also install plastic tubes through the eardrum to allow drainage. Like I said, the tubes, the normal auditory tubes in children are a lot more horizontal, and so they might need to put in a plastic tube that is going to be placed more vertically to allow drainage of fluid and pus. Sometimes they remove the tonsils to help allow fluid to drain freely. There's no real known way to prevent sinusitis, but sometimes they do surgery to widen the sinus passages and or remove scar tissue. All right, so I would love to now highlight an awesome disease in the fact that it's really, really important, an awesome disease in the fact that it is now considered an emerging disease. So this is a bacterial disease. We've been talking about the upper respiratory system. Now I want to transition to the lower respiratory system and talk to you all about tuberculosis. Many people do think, like I mentioned, that tuberculosis is a disease of the past, and it has little importance to our lives today. But now we know that tuberculosis is emerging again. It's becoming more and more prevalent. What's really scary about this is that tuberculosis has evolved antibiotic resistance. There are strains it's caused by Mycobacterium tuberculosis. This is a bacterial strain that has now evolved. There are some strains, that have evolved resistance to all known antibiotics, and there are no known ways to treat people infected with the resistant strain. These people are basically put into quarantine, and they then live out the rest of their lives in quarantine. So as far as past goes, tuberculosis, many people say, has probably killed more people in history than any other disease. Even today, it kills on average 4 people per minute, mostly in Africa and Asia. But there are people infected in the U.S. The CDC estimates that more than 9 million Americans are currently infected with tuberculosis. All right. How could somebody be infected with tuberculosis and not know it? Because 9 million Americans, that's a lot of people infected with tuberculosis. I'm going to show you the stages of infection with tuberculosis. And fortunately, or unfortunately, maybe you would think of it this way, is when you're first exposed and infected with tuberculosis, you don't have signs or symptoms. Your immune system is able to hold it off for a long time, actually. It can hold it off until it becomes weakened many, many years later, when the bacteria then are able to take over and kill you. So as far as signs and symptoms go, they're not going to be initially apparent. But once they are, you're going to have minor cough and mild fever at the beginning, if you do have signs or symptoms, because some people do. Now, as it progresses, though, and tuberculosis takes over the body, you're going to have breathing difficulty, fatigue, malaise, weight loss, chest pain, wheezing, coughing up blood to characterize the disease as it progresses. And then as it goes further and further, and you end up with disseminated tuberculosis, every organ is basically affected. All right, so tuberculosis is unique in the fact that it also has in its cell wall a very waxy substance. This waxy substance, think of like a wax like a candle. It's not dissolved in water, so it's very water resistant, and it basically prevents them from drying out. And so they can last in aerosol drops for up to 8 months. All right, so they can remain viable outside of the body on a fomite or in an aerosol drop for a very, very, very long time. All right, there are 3 types of tuberculosis: primary, secondary, and disseminated, that I want to talk to you about. Let's look at this. All right, so let's look at, this looks like a crazy figure, but it's not so bad. I'm going to explain it from the beginning, and it's numbered with steps. We're going to look at the beginning situation and imagine someone is exposed. Let's imagine you have inhaled some respiratory droplets. Someone nearby has tuberculosis, and they're coughing out respiratory droplets full of the tuberculosis bacteria. You're nearby, you inhale the respiratory droplets, and it goes down into your respiratory system, down into the bronchus, down from there into the bronchiole, and down into the alveolar sacs. All right, and so what's happened now in image 2, we see the gram-positive rod. That's what these bacteria are. These are rod-shaped bacteria, Mycobacterium. What's going to happen at this early stage when the bacteria are inhaled? You have in your alveoli, you have these things called alveolar macrophage. These are macrophages that wander around the alveoli looking for invaders. They will phagocytize the bacteria. So they will eat the bacteria. And more macrophage will come and eat up all the bacteria. All right. Now, unfortunately, though, the bacteria are not killed. All right. Once inside, these bacteria are able to produce antiphagocytic chemicals. All right. These chemicals cause incomplete phagocytosis. They don't prevent phagocytosis, but they prevent digestion. So this is incomplete phagocytosis, all right? The bacteria are not digested, so they're not destroyed inside the macrophage. The macrophage cannot kill these bacteria. And so what happens is the macrophage remain in the lungs, holding these bacteria inside. All right? More and more immune cells come. So here's the macrophage on the inside with the bacteria. Here's more and more and more. So we just get layers and layers and layers and layers of the immune cells coming, phagocytizing the pathogens, unable to digest them again, and the bacteria living inside. And so what you end up with is, and actually what's interesting is the bacteria are actually freely replicating, growing, multiplying inside the macrophage. All right, so the macrophage are basically holding them there. And it's basically going to gradually kill the macrophage as they replicate and grow inside. And so more macrophage will continue to come, because once some die, we need new macrophage to come and engulf these bacteria again. And so you get dead and dying macrophage in the middle. All right, and that's what they're calling this necrosis. All right, so this is dead and dying macrophage. New macrophage coming and joining to contain and wall off the bacteria. Your body will start putting down collagen fibers. These are proteins, little protein filaments that will work to help contain the bacteria. This structure is called a tubercle. And this is primary tuberculosis infection. So you've inhaled the bacteria. Your macrophage are trying to eat them. The bacteria are not being killed, though. They're growing and dividing inside the macrophage. They're slowly killing these macrophages. More and more macrophage come, trying to contain and keep eating and phagocytosing the bacteria. Your body tries to wall it off further with putting protein filaments around. And what happens is you get this little tubercle, this little nodule that forms. The bacteria are growing and dividing inside it, but the immune cells are strong enough, and there's more and more and more coming, that we keep the bacteria contained. So the person doesn't know they're sick. This is primary infection. They've got these little tubercles in their lungs, but they have no idea. All right. It could be a long, long time before you move on to secondary tuberculosis. Secondary tuberculosis occurs when the person's immune system, either they age, because when you age, your immune system gets weaker and weaker, or you get some sort of immunocompromising disease, some other infection, some other situation. Maybe you're being treated for cancer or organ transplant. Remember, we've talked about so many things that can lower your immune system. Maybe you're a drug addict. Maybe you've got poor nutrition, bad sleep, high stress. There's so many things that can add up. Your immune system weakens, and we stop fighting. And what can happen is, when the immune system weakens and they stop sending the macrophage to continually battle the bacteria in this tubercle, what happens is the bacteria can finally rupture out, and they can be released, and they can grow and divide all throughout the lungs. And that's when you start seeing signs and symptoms of actual tuberculosis. All right. Disseminated tuberculosis is going to happen, this figure doesn't show disseminated tuberculosis. We've got primary tuberculosis here with the tubercles. Secondary tuberculosis is when the tubercles rupture and the bacteria are released, and now they're growing and dividing. They will grow and invade and divide in the lungs. They can enter blood vessels and veins and travel to other organs. That's what happens in disseminated tuberculosis. Disseminated means it's really widespread. It's disseminated and spread throughout the body to other organs. That can happen. Disseminated TB results when the macrophages carry the pathogen by blood or lymph to a variety of sites, including bone marrow, spleen, kidneys, spinal cord, and even the brain. The common name for disseminated tuberculosis is called consumption. Consumption reflects the wasting away of the body, resulting from the involvement of multiple organs and multiple sites. All right. So, immunocompromised individuals are going to be those that are at most risk. It is the leading killer. Tuberculosis is the leading killer of HIV positive individuals. Risk factors, other risk factors can include things like diabetes, poor nutrition, stress, crowded living conditions, alcohol and drug abuse, smoking, any other reason that you would have lower immunity, even reaching elderly status. So as you age, it puts you at a higher risk. Diagnosis for this is done with a tuberculin skin test. All right, this is a skin test where they actually take pieces of the cell wall from tuberculosis bacteria and they inject them into the patient's skin, usually on the forearm or on the upper arm. And then they look for an appearance of a hard red swelling. If you have been exposed previously and you have tuberculosis, what's going to happen when they inject you with the pieces of the cell wall into your skin? Your immune system is going to react strongly and you're going to have redness and swelling of the area. Because your immune system is going to react really strongly because it's already been exposed and it's basically like already mounted a defense response. You've already got adaptive immunity. Remember thinking about that immune system. If you've been exposed the second time, you're going to generate a large amount of antibodies. That's what's going to happen here. You're going to have a huge immune response, and it's going to cause redness and swelling. All right. They can also do chest x-rays to look for those primary tubercles in the lungs. If either of these are positive, you're going to be treated with antibiotics. Now, the thing about this is these antibiotic treatments are really, really hard because tuberculosis bacteria grow really, really slowly. Antibiotic treatment can take 9 months to a year. You literally have to take antibiotics for that long in order to get rid or clear these tubercles from your lungs. There is a vaccine available. This is for Mycobacterium bovis. This is not for Mycobacterium tuberculosis. This BCG vaccine is for a tuberculosis strain that causes TB in cattle. It does provide immunity in about 80% of people that take the vaccine. But it cannot be given to those that are immunocompromised because it can cause disease in those people. All right, so here's an example of what a chest x-ray might look like if you had tubercles. So these fuzzy spots are tubercles, representative of primary tuberculosis. And then this is what it would look like if you had a positive tuberculin skin test. Now, the thing with this skin test is, if you have had the BCG vaccine, you cannot have the skin test because the skin test will always come positive to someone who has been exposed by vaccine. So it complicates things. All right, what I want you to do for tuberculosis, I want us to really kind of highlight and see a little bit more about this disease because I have a really, really awesome tuberculosis video. I love this video. It's really fun to watch. I've watched it over and over and I could watch it again and still like it. So what I want you to do is go onto Canvas, watch the tuberculosis video, and then answer the question set. So here is a screenshot from our Canvas site. If you go down to videos and question sets, here's typhoid Mary, there's superflu, here is tuberculosis. If you click on this link, it will take you to the video, and then there's a Word document there with a question set. And I want you to watch the video, and I want you to answer the question set. So I want you to type in your answers, save your document, and then I want you to upload your answers to Canvas by Tuesday, April 7th at 5 p.m. For credit, I'm going to give you clicker points for doing this. All right. Now, as far as Continuing with diseases of the lower respiratory system, there are other bacterial diseases of the lower respiratory system that are important. We should talk a little bit about bacterial pneumonias. The term pneumonia describes an inflammation of the lungs in which the alveoli and bronchioles become filled with fluid. There is an estimated 2 to 5 million cases of pneumonia annually in the U.S. And these can be caused by viruses like COVID-19, or they can be caused, it's SARS-CoV-2. COVID-19 is the disease caused by the SARS-CoV-2 virus, or it can be caused by bacteria. All right, so there's many, many causes of pneumonia. And there's actually, if you're thinking about, let's focus on bacteria first, because that's what I'm talking about now. There's a number of bacteria even that, and there's even fungi, I should mention that too, that can cause pneumonia. There's a number of bacteria: Streptococcus, Mycoplasma, like as in Mycoplasma tuberculosis, Klebsiella, I'm going to show you, Haemophilus influenza, these are bacteria as well, Staphylococcus, Yersinia pestis is the one that causes anthrax. There's even one called Chlamydophila. All right, pneumococcal pneumonia. Pneumococcal pneumonia is caused by Streptococcus, often caused by Streptococcus pneumoniae, but there are different species of strep that can cause this. Signs and symptoms are generally, this is the most common type of pneumonia, and it does account for the most pneumonia-associated hospitalizations. Signs and symptoms: fever, chills, congestion, cough, chest pain that's going to result in short, rapid breathing, and possibly nausea and vomiting as well. Blood will frequently enter the lungs, causing the coughed up sputum to be rust-colored. Pathogenesis is not fully understood. We don't know why these strep bacteria can reach the lower respiratory system, because remember we talked about the ciliary escalator, right? Remember, your lungs and your respiratory system is lined with cilia. The cells have cilia, and these cilia are constantly waving in an upward motion, and so they're generally trapping bacteria and moving them up and out. And we also know that about 75% of us have this bacteria in our mouths all the time, and we don't have pneumonia. So we're not sure why sometimes, and actually it's quite common, this bacteria, because it is the most common form of pneumonia, this bacteria makes its way down into the lungs and causes pneumonia. We do know that cigarette smoke actually is responsible for paralyzing the ciliary escalator. So it may, some people hypothesize, that cigarette smoke or exposure to other irritants like cigarette smoke could play a role in this. Because if it paralyzes the cilia, then they stop moving in that upward motion. And then we think that bacteria might then be able to make their way down, and the cilia aren't washing them up and out anymore. We do know that adhesins are really important. They are produced and secreted, and they attach the bacterium to the epithelial cells lining the respiratory tract. Some of them also will have capsules, which will protect against phagocytosis. Many of them have a cytotoxin called pneumolysin. This is produced, and it binds to the ciliated epithelial cells, and it causes the epithelial cells to die. So this lyses them. It lyses the ciliated epithelial cells that are part of the ciliary escalator. So that may play a role as well. As far as how you catch this, like I said, it is part of the normal microbiota of about 75% of us. So it could just make its way down there from its normal location, or if it's not part of your normal microbiota, you could inhale it. As far as treatment goes, Penicillin is the drug of choice. And prevention is done by vaccination. So pneumococcal pneumonia, we generally are vaccinated at 2, 4, 6, and then 12 to 15 months of age. And then they will give a booster for adults over the age of 65. So that's why we don't commonly see this causing that much of a problem. Here is an image of Streptococcus pneumoniae, and it just shows you the capsule around them. These are gram-positive coccus-shaped cells. Excuse me, I can't talk. All right, Klebsiella pneumoniae. This is another type of bacterial pneumonia. This is a gram-negative rod. This one also is a leading cause of pneumonia, but this is a leading cause of hospital-borne pneumonia. So this is a nosocomial pneumonia. This one, signs and symptoms are going to be basically everything we talked about before. We're definitely going to see a thick, bloody sputum being coughed up because alveolar cells will die. And release blood entering the lungs. Also, bacteria in this case can generally, invade the bloodstream and cause bacteremia, which is septicemia. That means bacteria infecting the entire body. It can even cause meningitis. Obviously, it causes pneumonia. We're sitting here talking about that. It can even cause meningitis when it infects the membrane that surrounds the brain. Immunocompromised individuals are at greatest risk for infection, and mostly those that are immunocompromised and in the hospital for some other type of treatment. If someone does get Klebsiella pneumonia, they will be treated with antibiotics. Prevention of this is going to involve good aseptic technique, which means sanitation, hand washing, cleanliness. Very, very important. No vaccine is currently available against this type of pneumonia, so we must rely on sort of good hygiene. Here's an image of Klebsiella pneumoniae. It's showing you the capsules. So this was a negative stain where the bacteria is stained with a dark color. The background is stained, but the capsule is not. So the capsule is negatively stained or not stained, and that's what's making it visible. So it's kind of cool looking little image there. There's other bacterial pneumonias. I won't talk about them that often or in that much detail. There's Haemophilus influenzae. This is a bacterial strain or a bacterial genus and species that they used to think caused the flu. That's why it's named influenza as its species name. Now we know it causes pneumonia. It does not cause the flu. And then there's staph bacteria that can cause pneumonias as well. These cause a disease very similar to that caused by strep, the pneumococcal pneumonia we just talked about. There's also Yersinia pestis. Remember, Yersinia pestis causes bubonic plague. And if you remember, we talked about the pneumonic plague, which is plague in the lungs. There's also this chlamydophila, which is a disease of birds that can be transmitted to humans. This is kind of rare. There's Chlamydophila pneumoniae as well. So I won't ask you about these two. Why don't we just X these two off? And let's focus on Yersinia pestis, Haemophilus influenza, and Staph aureus. Let's skip Legionnaire's disease. We will not talk about Legionnaire's disease. Let's remember, I'm not going to cover this in much detail right now, but let's remember that we talked about pneumonia caused by anthrax as well. Remember back a long time ago, we talked about Bacillus anthracis. We talked about it with regards to endospores and toxins. And we talked about the fact that you could have inhalational anthrax, in addition to the cutaneous skin infection or gastrointestinal anthrax. There was the inhalational anthrax. It initially resembles a cold or flu, but it progresses very quickly to severe coughing, lethargy, which is, sleepiness, no energy, shock, and death. Let's see. We did also cover viral diseases of the respiratory system. And so we covered this the Tuesday in class before we left for spring break. I'm just going to quickly kind of shift through it to remind you of what we covered. Remember, we talked about the common cold. We talked about influenza. Remember these slides? We did not talk about, yes, we did. We talked about SARS, and this is when I led into the coronavirus, and we did the COVID-19 activity, okay? The only viral disease we have not talked about yet is respiratory syncytial virus infection. This is a very common childhood infection caused by respiratory syncytial virus, or RSV. This virus is more common in newborns and children, and if it occurs in adults, it generally resembles a cold. However, in children and newborns, it's very, very severe. It triggers runny nose, fever, coughing, wheezing. It's the leading cause of pneumonia among children less than 1 year of age and the leading respiratory killer of infants worldwide. As far as pathogenesis, what happens here is really unique. It causes these things called syncytia to form in the lungs. I'm going to show you an image. These are places where infected cells will fuse with uninfected cells. All right, and then what can happen is the virus will spread through the cells in the cytoplasm. It doesn't actually have to leave a cell, bind to a receptor, and enter a new cell, so to speak, okay? The first time it infects the cells, it does. The first time the virus would infect the first cell, it would bind with its receptors to the cell, then it would enter the cell and begin replication. All right, so that must happen in the very first cell that's infected. However, if you have a cell that's infected, what will happen is this cell will fuse to neighboring cells. And this cell will fuse to another neighboring cell and fuse to another neighboring cell. Here's an uninfected cell it's about to be fused to. All right, and what can happen is the infected cell, once it fuses, the virus then can cross over into the new cell. And so you end up with these large conglomerates of fused cells, regions where the lung cells in the alveoli, so these are alveolar cells that are fusing now, and the virus is just freely moving back and forth among these cells. All right, transmission is going to occur by respiratory droplets or close contact with infected persons, kissing, touching, shaking hands, recently contaminated fomites. It's going to be more problematic, like I said, in babies or infants, especially those that are premature, immune impaired, or exposed to tobacco smoke, those who attend daycare, or maybe those who have older school-age siblings are at most risk. RSV is prevalent in the U.S., and studies reveal that about 98% of children in daycare are infected by age 3. About 125,000 of these require hospitalization each year, and about 2,000 die. And then additionally, RSV kills about 14,000 elderly patients each year because older or immunocompromised patients are also at risk. All right, so that's the end of the respiratory system disease PowerPoint, or infectious disease PowerPoint. I do want to remind you, again, go to Canvas, watch the tuberculosis video, answer those questions, post them by April 7th for some clicker points. Let me know if you have questions. Again, I will be having Zoom office hours for you to come into, or Zoom in if you want. You can ask me questions, or you can email me to ask questions as well.